This is the Voice of Russia in London. I'm Juliet Spare. A city in England could become the first in the UK to provide safe rooms for drug addicts to inject themselves. Brighton and Hove Council are considering providing official consumption rooms where addicts can use heroin, crack and cocaine under supervision, but without fear of prosecution. For decades, more people have died because of drugs in Brighton and Hove than any other area in the country. Out of the 270,000 people who live there, more than 60,000 have used drugs at some point in their lives. And 2,000 people today are still battling with their addiction. So the local council is now considering a different approach to combating drugs. Here to discuss whether consumption rooms are a good idea is Chris Snowdon from the Institute of Economic Affairs and author of The Art of Suppression. Chris's research focuses on pleasure, prohibition and statistics. Councillor Jarrett from Brighton and Hove, and he's chair of the Adult Care and Health Committee. Jamie Bridge is Senior Policy Manager at the International Drugs Policy Consortium. Deirdre Boyd is Chief Executive of Addiction Recovery Foundation, and Mark Dempster, a former drug addict and now Harley Street drug counsellor and author of Nothing to Declare. First of all, I think I'm going to start with you, Mark Dempster. Do you think these consumption rooms where addicts can go and take drugs are a good idea? What do you think of Brighton and Hove's plans?
I think, the main reason that they've instigated having these consumption rooms is to reduce drug-related death. And I actually feel that they've not considered various other options. As in naloxone pilots and such like, other ways to reduce drug-related death. I think the whole harm reduction ethos, which we've been involved in for the last 20, 25 years, has become out of balance. And I think with the drug strategy from 2010, which was promoting and ensuring that we have a more ambitious workforce and pushing people towards full recovery, I think this is actually like going back the way in so many ways. We're going back to the 70s and the 80s when we used to have wet houses like Roma House, and where people could go along there and drink and use drugs. And there doesn't seem to be any clear evidence that this actually is effective.
Councillor Jarrett, you're representing Brighton and Hove, who has outlined these plans. What's your response to that?
If I can start by emphasising that these are recommendations by an independent commission, which will then come to the authorities, which will be considered by the authorities. Now, there were 19 recommendations in that report, but the attention, understandably, has focused on one out of those 19 recommendations. A whole host of other integrated approaches are being recommended. We anticipate that these consumption rooms will not be used by everybody. We have a number of other programs that people are already involved in. We strongly support the recovery approach, and we supported the recovery walk in Brighton last September, and we are supporting the setting up of a recovery cafe. But there are some people that do not engage with our services, particularly homeless people, and we anticipate that some people will come into these consumption rooms that we do not currently engage with, and it will give us an opportunity to engage with them and then carefully and gently to move them on into a recovery program at their own pace when they're ready. But first of all, we have to stop them dying. That's the first step. If you're dead, recovery is not an option. Then we have to move them through the system in a way that suits them, with a system that meets the needs of the different people that are going to be coming through it. 8 countries are doing it at the moment. Another 2 are considering it. It's been very successful in Germany, in Holland, in Switzerland, in Canada. And I regard this, along with other measures, as a step forward. What we want to move to is an evidence-based drugs policy. We want to leave behind knee-jerk hysteria.
Jamie Bridge, you're the Senior Policy Manager at the International Drug Policy Consortium. What do you think about the idea of consumption rooms?
These centres are nothing new. They have been in existence for several years now, almost a decade in places, in 58 cities across the world. And to come back to Mark's point from earlier, we do now have a growing and solid bank of evidence that's out there to show that these things are having an effect. Most, importantly, on drug-related deaths. but also on reducing crime and on helping people refer into other treatment services. And this is the key point. It's around these services allow you to engage with people who otherwise wouldn't engage with a health service. And these are health services. From when you work in one of these services, I myself used to work in a needle and syringe program. You're seeing people every day. And sometimes you're the only health worker that person is engaging with. And that allows you to be there when that person has that, I don't know, moment of clarity or has that crisis or has that change of heart and decides that they want to make a change. And that's why these services are so important as part of this balanced drug strategy, where we are helping people to achieve recovery when they're ready. And in the meantime, we're keeping them safe and we're keeping them alive. And these drug consumption rooms play an important part in that.
Chris Snowdon from the Institute of Economic Affairs. Does this go far enough? Is there not an argument for it going all the way and making certain drugs legal, decriminalising them? What's your thoughts on the consumption room?
Well, I think it's an example of institutional hypocrisy. I'm in favour of the rooms as it happens. I'm not, I can't say I'm fully in support of them. It's rather half-hearted support because I think that the beneficial effects are fairly modest. But by the same token, I don't think any of the unintended consequences that are sometimes predicted by supporters of the war on drugs have come about either. So for the health reasons that have already been given, I would give it at least one or two cheers. But the very fact that we're in this situation trying to clear up this mess, that on the one hand we have the state saying that these drugs are so bad that if you sell them we'll put you in prison for 7 years, but on the other hand here's a room where you can take them and here's a syringe that you can use them with. This is the point we've got to with prohibition of drugs in this country, where the damage of prohibition, and it is primarily the harm of prohibition we're dealing with, not the drugs per se. The harm of prohibition has become so acute, particularly in places like Brighton, that we now have to get local government to try and pick up the pieces by giving people syringes. Now, I don't have any real moral objection to people taking drugs as such, but I do understand and I can sympathise with people who do think that drug use is morally repugnant. I can understand that they would be upset at the idea that their tax money is going to supporting and certainly facilitating the use of hard drugs. There's clearly a double standard going on here. My solution would be to have a law that we can actually believe in, which is consistent and which is basically legalisation.
Deirdre Boyd from the Addiction Recovery Foundation. You've heard from everyone here on the panel. What's your thoughts?
I'd like to correct some of the inaccuracies that have been said for the benefit of your listeners. First of all, the analysis of the research, and there's been a study in the Journal of Global Drug Policy, and it showed that there were little or no reductions in transmission of bloodborne viruses, no impact on overdeaths, even in Vancouver, which had the original on-site inside facility. There was a failure to reach people earlier in their injecting careers, and there was actually little or no movement of drug users into long-term recovery and treatment. And there is also, in the UK, I have found in 20 years working in this field, a vast difference between theory and reality, theory and implementation. And it would be great if Rob Jarrett was actually correct and, some harm reduction facilities were actually used as engagement, so people did go through the recovery process. But too often they're standalone. And not only do they not work, but the research that applies to the full spectrum of programs doesn't actually apply to standalone projects. It's a very different setting. I'd also like to address the myth of harm of prohibition in Brighton. I would say that the reason Brighton has about double the national average of, with 2% of the adult population being chronic problem users and 4% regular users, is actually not because of prohibition, but because of its anything-goes nighttime culture, its clubbing and drugging reputation, which actually attracts people to Brighton, known as the clubbing and drugging capital of the UK. And perhaps here, the Brighton Council has a responsibility. It has a tolerance of licensing hours. It licenses establishments that seem to encourage this, and the residents know it. The Centre for Policy Studies recently quoted a resident saying that there seems to be a feeling that drugs are okay, that despite the social and personal harm they cause, there's a collective fingers in the ear approach to the real nature of the problem. And that was addressed to Brighton County Council. And it's important that the council now knows, because commissioning decisions are going down to the council and the health and wellbeing boards in which Rob Jarrett sits. And my final point for Rob would be, would your money not be better spent on other things? Consumption rooms are expensive to set up, they're expensive to run, they're expensive to staff, they're expensive to keep hygienic. If they do bring in these football games and TV things that some of the newspapers say they will that not attract vulnerable and impressionable youngsters to actually start?
Okay, thank you, Deirdre. What you can't see here, because you're on the telephone, is Rob is shaking his head in disagreement. So we're going to ask for your response then, Rob.
Let me emphasise, please, that this is a recommendation coming to the council. It's an integrated package of 19 recommendations. A lot of the recommendations are about better joined-up working between all the agencies. So this is not going to be a standalone project. This is a missing part of a jigsaw. In terms of cost, if you look at the cost to the NHS of ambulance time, of visits to accident and emergency, to the costs that arise from an unnecessary death, those costs far outweigh the cost of setting up and running this room.
But running those rooms could actually increase those costs. They could be a hotspot for HIV and hepatitis infections. There's a problem for policing nearby, as police find people in possession of street heroin or crack, for example. The facility could attract dealers because it's got a lot of potential customers in one place. I mean, could it not actually aggravate and increase your costs?
Okay, Deirdre, thank you. I'm going to come to Jamie Bridge now from the International Drug Policy Consortium. You're also shaking your head.
Thank you. We have experience now from several countries that have had these services in place for a long time. And that experience tells us that these fears are unfounded. These places do not become They do not become honeypots. Sorry, Deirdre, if you let me finish. They do not become honeypots for drug dealers. They do not increase the local levels of harm or problems or anything like that. And the key thing to stress here is that these are not social clubs. These are not youth clubs that we're going to allow injecting to take place in while people watch, the football on TV. These are medical facilities. They're sterile health facilities. I've had the pleasure of visiting services in Vancouver, in Canada, and also in Geneva in Switzerland. And then medical services where you have medical staff present. It is not something that promotes the use of drugs. It's something that deals with people who would be using drugs anyway on the street, and you're giving them a nice, sterile, safe place that they can use the drugs that they were going to use anyway. I think the decision for someone to use drugs is a multifaceted decision. It's a complex decision that someone takes in their life for various reasons. Whether or not there is a room that you can inject, I think that comes so far down the list of possible factors in that decision that I really don't agree with the argument that this is something that's going to promote drug use in Brighton.
Okay, Mark, Dempster, I'd like to come to you then. What would you think?
Speaking from an ex-drug user perspective too, I think there's a number of different factors. I think immediately when Deirdre said about the drug dealing, it would be the first thing that I would think about. If I was, back in the day using drugs, it would be a good place to go and cop drugs or to score drugs. I'd think, definitely, mate. Right, that's one perspective. I think it's also naive to believe that the client, right, also around, when we're thinking about drug-related death and bloodborne virus, that a client is going to automatically change his whole using behaviour, i.e. that every time he wants to inject drugs, he's going to come to this facility. Because what happens at street level is the client gets drugs in a car park outside Tesco's. They'll go into the toilet in Tesco's and use the drugs there. they might come to that facility maybe once in the day and use the drugs there just maybe once or maybe twice in that whole day. But the rest of the time, from the morning they open their eyes and they start using in the morning to the minute they close their eyes, they're going to be injecting a lot other times during that. And I think, of course, then there's a potential risk of them having a drug-related death or getting a bloodborne virus. So I think it's naive to think that all of a sudden we'll have this service and everybody's going to come along and everybody's going to be using drugs there, and we're going to eliminate the drug-related deaths. We're going to reduce that significantly, because I don't think that's going to be, and there's no evidence to suggest in these other countries where it's been devised that is happening. There's no clear evidence. Thank you.
You're shaking your head again, Rob. You should respond to this, really.
Well, I would refute any claim of naivety. I wasn't born yesterday, and neither were the people on this commission. We have a lot of experience here. We are working from experience that's been given to us from addicts, from current users, from recovered users, and from a lot of people that have worked in the field. We know there are certain things that we would have to have in place before this could be successful. We have to have an agreement with the police about how it's going to work. We have to have a very clear no-dealing policy that would be rigidly enforced in the rooms and in a prescribed radius around the room. There has to be a rigidly enforced antisocial behaviour and no-dealing policy. And we also understand that a user will quite probably wish to inject shortly after purchasing their drug. So we recognise that. So we know that we have a tricky situation to get this thing to work. The alternative to getting this to work is that we don't get it to work. People will carry on dying. People will carry on getting bloodborne diseases. People will carry on leaving needles in car parks and in parks where our children will come across them. This is a harm reduction measure for the whole community, and we can make it work, and we will consider very carefully if we can get it to work in this country. David Cameron in opposition was very keen on getting something moving on drugs and getting into a slightly better position on how we dealt with the position. And I would like to hear some positive responses from the government.
You're listening to The Voice of Russia with me, Juliet Spare, and we're talking about providing rooms for addicts to take drugs in certain cities. I'm joined by a former addict and now author and drugs counsellor, Mark Dempster, Jamie Bridge from the International Drug Policy Consortium, Chief Executive of Addiction Recovery Foundation, Deirdre Boyd, Councillor Rob Jarrett from Brighton and Hove Local Authority, and Chris Snowdon from the Institute of Economic Affairs and author of The Art of Suppression. You gave it a couple of, maybe 2 or 3 cheers in the beginning. Do you think this goes, having heard a bit more from the panel then, do you not think this is actually a really positive step, and there might be hope that other councils follow suit, and this might have an impact on the international war on drugs in some way?
I think that it's nice that we've got a natural experiment here, and one of the good things about the way that public health services have been sort of decentralised this year is that we will see more of these natural experiments, and so we'll be able to have a bit of empirical evidence about what works and what doesn't work. My feeling is, and I don't think anybody here is saying it's going to radically slash the number of deaths, my feeling is that the benefits will be quite modest. As for the implications for the war on drugs, I know that there are some people who are keen supporters of the prohibition of drugs who think that harm reduction is a Trojan horse for the legalisation of drugs and so on, and that is not the case for many people. With me, it is. Guilty as charged. I think that the real way to get to the bottom of this problem and to sort it out is to undo the entire war on drugs that was been going on for over 100 years now. People did not used to inject heroin intravenously. This is something that's only come about as a result of the war on drugs. People used to smoke opium. So never mind that the shooting galleries. Let's have opium bars. That's what we really need. Of course, it will never happen. You can't even smoke in a bar these days. Although you can, maybe in the near future, inject heroin in a state-owned premises. So there is an enormous double standard and hypocrisy going on here. We're not. Things are not logically laid out quite clearly. I'm very sceptical about whether we'll see any kind of legalisation. I think possibly in my lifetime we might see the decriminalisation of cannabis. I think what's been happening in America recently is very encouraging. Again, you'll have another natural experiment in places like Colorado. The fact of the matter is, when countries and states and towns liberalise their drug laws, there's very little demand for them to go back to prohibition. That's been the case in Portugal. I'm sure it will be the case in America. It's been the case in Holland as well. So prohibition doesn't work. This is a fairly modest, but I think basically commendable strategy being taken on in Brighton, but I don't think anybody is claiming it's going to be the solution to it. It's just, as Rob says, it's one of many ideas that came up, and the media has picked it up and run with it because it's controversial.
But also it does give rise for another dialogue about drugs and the legalisation and decriminalisation and what is working and what's not working, especially when you have got states in the US decriminalising cannabis. I mean, Deirdre Boyd, you say you worked for 20 years in drug recovery addiction. Mm-hmm. What does work?
Well, I think if the law was actually implemented and if the rhetoric and the aims of the drug policy were, for example, it refers to recovery from dependence, which was changed in all the documents since to recovery from drug dependence, allowing cross-addiction, etc. But if the actual aims of the government were implemented, I think that might work. I think that if there was, as some people aspire to, fully joined up working with a good aim, but we seem to see too often that harm reduction is not used as a form of engagement, but as standalone. And we seem to see too often that there is an attitude of despair, really, of seeing health as characterised by death rates rather than life quality, of focusing on benefits for the community rather than getting the addicts well. And finally, I'd like to say this myth yet again, that even that there is a prohibition, but the myth of that it's not working or the war on drugs is not working. Of course it is. If you compare deaths or the harms caused by illegal drugs to those that are legal, tobacco kills, 100 times more people a year than alcohol, than illegal drugs, rather. Alcohol kills 10 times as many. And even just the plain business argument of supply and demand, the more drugs are available, then the more people are going to use them. And my final piece about so-called prohibition, it's not just that it does keep the harms from illegal drugs far, far, far lower than the legal ones. But also, if you didn't have a 100% clear-up rate in murder or rape or burglary, would you then make it legal? Do you actually think that would reduce murders?
Well, what you're saying is just about the harms of drugs is just nonsense. The overdoses are the direct result of prohibition. The heroin is not inherently lethal. It kills people when the purity is...
Hold on, Deirdre, let Chris speak.
The heroin overdoses result generally from people getting heroin, which is unusually pure, because due to prohibition, we're used to it being 20, 30, 40% pure. It's the contamination of the drugs, which is a direct result of prohibition. You cannot deny there's prohibition when you can't go into a shop and buy it. Clearly, it is prohibited. It's even prohibited to possess it, which is more than was the case with alcohol under what we know as prohibition in America. Nearly all the harms, and certainly nearly all the deaths that come from drugs are a result of the product being impure because it's not regulated, or being taken in dangerous ways such as intravenous injection, which again are direct products of prohibition.
I would say it's a product of not enough emphasis and funding going on demand reduction, that there's not enough good enough prevention in schools.
100 years we've been through this now. When's it ever going to change? How much empirical evidence do we need that this doesn't work?
Jamie.
But you don't have it.
I think the crucial thing here is, there is now a growing acceptance around the world that this war on drugs has failed, or at least is failing in terms of, it is not created this drug-free society that was aspired to, as recently as like the 1980s, 1990s. The claims, the comparisons between illegal drugs and the likes of alcohol and tobacco are incredibly flawed, because there's never been, those different drugs play a very different role in our society. And there's never been a situation where all those drugs were being used equally, and then because two of them are legal and the rest of them are illegal, they've gone on different trajectories since then. Heroin and the other illegal drugs, they've never been used on that same scale. So the comparison is completely flawed. And to claim that the heroin use remains low as a result of the war on drugs is a bit of a desperate approach to try and, protect the status quo, in my opinion.
Actually, I wasn't saying that. What I will say is that drug usage will increase to the levels of alcohol and tobacco if they are made just as freely available.
No. So we have the evidence from the likes of Portugal that have now gone through a decriminalisation approach. We have the evidence from there that drug use, it didn't necessarily reduce, but it certainly did not increase. It did not create this kind of drug use apocalypse that people seem to be scared of.
Well, the thing about Portugal is that it's just like the Bible. People can argue exact opposite points of view from the same pieces of paper.
Yeah, I'd like to come to you, Mark.
I'd just like to say, because I've worked in, like Deirdre, I've worked in drug and alcohol services for 16 and a half years now, and I'm responsible in Hackney Borough for looking at all drug-related deaths. Most of the drug-related deaths are a result of people using other chemicals, not just, sometimes it is about the purity of the heroin, but often it's not, because often the clients using benzodiazepines, they're using lots of alcohol on top of heroin, which of course are putting one depressant on top of another, which leads to the death. Now, what the problem with this is that there's lack of clear information within services around giving clients all the knowledge around what's likely to cause the problem. And I think if we're looking at, and I really like what you were saying, Rob, about, that it's one of several recommendations, but there has to be clear information for services to the client group around the possible risks, but also I think the resources that we're putting into these consumption rooms. I just know that a lot of people in the Brighton area struggle to get funding for residential rehab and detoxification, and because there's limited budgets. And I'm just looking at, you put a lot of money, take money from, you're generating money into these consumption rooms, but at the expense of, where people that really want full recovery are still struggling to get the money to get into residential rehab. And I just think the resources could be utilised in a different way.
You're listening to The Voice of Russia with me, Juliet Spare. I'm joined by Mark Dempster, a former drug addict and author of Nothing to Declare, Chris Snowdon from the Institute of Economic Affairs and author of The Art of Suppression, Jamie Bridge, Senior Policy Manager at International Drug Policy Consortium, Deirdre Boyd, Chief Executive of the Addiction Recovery Foundation, and Councillor Rob Jarrett, who's the Chair of the Adult Care and Health Committee at Brighton and Hove Council.
Residential rehab is a lot more expensive than a consumption room, and a consumption room can help an awful lot of people in one day. So you've got to look at numbers and efficiency and integrated service and having the range necessary that's there. In terms of naloxone, and naloxone is the reason that we are down to about number 8 in the death league table now. So long as naloxone is available, people know how to use it, then you can prevent death from overdose. Now, the consumption room is one more place that we can have naloxone handy, have people that know how to use it and stop people dying. Other places have been using this very successfully, and it prevents death. But that's only if there's somebody else nearby. If you are injecting by yourself in a stairwell or behind a bush in a park or on the seafront in the dark, and you overdose and there's nobody with you, then you die. And we are trying to stop that. And as far as I'm concerned, if we save one unnecessary death with this programme, that is worthwhile.
That was Rob Jarrett, the Chair of the Adult Care and Health Committee at Brighton and Hove Council. And I'd like to thank all my guests: Mark Dempster, former drug addict and author of Nothing to Declare, Chris Snowdon from the Institute of Economic Affairs and author of The Art of Suppression, Jamie Bridge, Senior Policy Manager at the International Drug Policy Consortium, and Deirdre Boyd, Chief Executive of the Addiction Recovery Foundation.